Well, good afternoon, and we'll take the liberty of starting on time. So this is about multiple endocrine neoplasia, and actually this particular case symbolizes that. I've very rarely seen such multiplicity, and it's been academically challenging to work up this case. And really, what I want people to focus on is the fact that whatever has been done is a consequence of a significant collaborative care between multiple institutions and multiple expertise. And that's the strength of, people coming to a place like AIIMS. And I think this exemplifies that. The science will be dealt with by Saurabh.
Thank you, sir, for your kind introduction. I am Dr. Saurabh Das, Senior Resident in the Department of Endocrinology and Metabolism, and I'll be presenting today's clinical combined rounds on multiple endocrine neoplasia, how many are to know. So we present a case of Mrs. X, 54-year-old female, resident of Kathmandu, Nepal, who is a homemaker by occupation, had presented with fragility fracture of the left shaft of humerus 8 months back and sudden onset right hip pain 4 months back. On evaluation, it was found to be hypocalcemia, which was PTH dependent with IPTH of 2456 picograms per ml, and she underwent a CT-guided biopsy of a lesion in the right ileum, of which the CT showed multiple pancreatic and adrenal lesions, for which she was referred to AIIMS New Delhi due to syndromic suspicion. On initial evaluation, her spine blood pressure was 132 by 84 millimeters of mercury on 2 antihypertensives. She also had pallor and bilateral pitting edema up to the ankles. Also, on evaluation, she was found to have Cushing's stigmata, which included thin skin and chemosis with easy bruisability, wide dehiscent striae, and proximal myopathy. She also had multiple skin lesions, which were suspected to be lipomas and collagenomas. On further evaluation, she was also found to have acromegaly stigmata, which included coarse facial features with broad, fleshy nose, thick facial creases, and furrowing of the forehead. On investigation profile, we found that she had a significantly elevated calcium of 14.4 milligrams per deciliter, which went down up to 11.6 milligrams per deciliter on IV saline infusion and zoledronic acid injection. On further evaluation, she was found to have a normal thyroid profile, and prolactin and IGF-1 were significantly elevated, while the intact PTH was also elevated with an insufficient level of 25-hydroxyvitamin D. Adrenal evaluation was done because of the adrenal lesions that were identified, and she was found to have an elevated ATM serum cortisol with a low DHEAS and an elevated 11 PM salivary and awake serum cortisol, which signifies the loss of diurnal rhythm, and also on post-overnight dexamethasone suppression test and low-dose dexa suppression test, both were elevated, which signified the loss of suppressibility. Further evaluation also showed that the ACTH was more than 10 picograms per ml, while the post-high-dose dexa suppression test showed more than 50% suppression, thus signifying likely ACTH dependence. Coming to the further evaluation for the adrenal tumors, she underwent plasma-free metanephrine and normetanephrine levels, which are normal, and normal plasma aldosterone and diacrinin concentration were noted, which rules out the likelihood of pheochromocytoma and primary aldosteronism. So coming to the further evaluation of the pancreatic tumors, she underwent a neuroendocrine tumor profile, which showed a significantly elevated plasma chromogranin level with normal gastrin and calcitonin levels. She also underwent endoscopic ultrasound, which showed 3 hypoechoic pancreatic lesions, 2 in the tail and 1 in the body, the largest being 2.9 centimeters in the largest dimension in the body of the pancreas. So coming forward, I would like to invite Dr. Arun, followed by Dr. Yogita, to talk about the structural and functional imaging that were found in the patient. Thank you.
Good afternoon, everyone. We have provided with the multiple representative images of a patient, which was done on August of 2023. Here we see there is a ill-defined, mildly T1 hyperintense lesion seen involving the sella predominantly on the left side. On the T2, lesion is appear bright with dependent dark signals, which is suggestive of dependent hemorrhage within the lesion. There is a mild deviation of pituitary stalk on the left side. On the dynamic images, there is no significant differential enhancement seen within the lesion. So on the basis of our finding, we will like consider it is pituitary microadenoma, which is residual with partial pituitary apoplexy. Next is provided with the 4D CT neck images of a patient. Here we see there is a multiple well-defined solid lesions, by at least 4. One of the lesions which is seen in the inferior pole of right lobe of thyroid, which is size around 2 into 1.7 centimeter, which is appear hypodense as compared to thyroid lobe on NCCT. The same lesion appear hyperenhancing on thyroid, hyperenhancing to the thyroid lobe as compared to on arterial phase imaging, and mildly washout seen on venous phase images. Similarly, there is another lesion of size is 4.4 centimeter, 1.5 centimeters seen on the posterior inferior aspect of left lobe of thyroid. This lesion is seen encasing in reaches anterior in the pretracheal region and on left side it is the left paratracheal space also. There are 2 more lesions seen having enhancements similar to the thyroid gland seen in the superior aspect of right lobe of thyroid, which is shown in the image there, and the superior aspect of left lobe of thyroid, which is shown there, which are suggestive of multiple parathyroid adenomas. Next is the image showing the CECT abdomen. Here we acquire both NCCT images, contrast enhanced images, and the 15 minutes delayed images. Here we see the 2 well-defined solid round lesions of sizing in approx 4.4 centimeter into 4 centimeter and 2.7 into 2.5 centimeter. After calculating their washout, here we calculate the absolute washout, which is 45% in the right lesion, and relative washout is 34%, which is suggestive of keeping the figure of differential diagnosis is atypical adrenal adenoma, the second possibility of adrenocortical carcinoma, and third maybe paraganglioma. However, on the left side, the lesion appears small and showing the washout values is around 80% and relative washout is 75%, which is suggestive of typical adrenal adenoma. Now back to the CECT images of a patient. Here we see there are 2 arterial phase enhancing lesion. One is seen in the body, the size is approx 2.7 into 2.1 centimeter. Another lesion which is seen in the tail of pancreas, which is 10 cross 7 mm. These lesions are the hyperenhancing of arterial phase, which is suggestive of neuroendocrine tumor of pancreas after correlation with the promoternal level. So these are the CECT chest images. Here we see there is a well-defined round solid nodule of size around 9 mm seen in the basal segment of left lower lobe. So it's not look like benign, and here we keeping it's like a metastasis from the right adrenocortical carcinoma, or it can be a carcinoid. Next, these are showing the bone lesions, the multiple extensile lytic lesions seen on the humerus, left humerus, and the ribs, both right and left side, and the inferior pubic rami, which is suggestive of Brown's tumor. Next is the functional imaging, which is discussed by Dr. Yogi.
Good afternoon, everyone. I'll be discussing the functional imaging. So this patient was referred to us for evaluation of PTH-dependent hypercalcemia, for which underwent 99M technetium MIDI scintigraphy. These are the planar images acquired 15 minutes and 2 hours after the injection. So apart from the physiological tracer uptake, a lesion is noted inferior to the right lobe and one corresponding to the left lobe, for which SPECT-CT was done for the localization. A soft tissue lesion was seen posterior to the right lobe, showing no significant tracer avidity. Another lesion was noted posterior to the left lobe, showing minimal tracer avidity. A third lesion was noted inferior to the right lobe, showing intense tracer avidity. And another lesion is noted posterior inferior to the left lobe, showing mild tracer avidity, representing multiple parathyroid adenomas. Same is shown in coronal imaging. So patient was also referred to us for 68 gallium Dotanoff PET-CT for evaluation of neuroendocrine tumors in the background of MEN syndrome. So these are the MIP imaging, which was acquired pre-surgery and post-surgery of total parathyroidectomy and pancreaticosplenectomy. So there are 2 abnormal foci representing the pancreatic lesion and the adrenal lesion, and the adrenal lesion is visible in the post-surgery images as well. Apart from this, in the post-surgery images, a new area of abnormal focal tracer avidity was noted in the abdomen, which we will localize in the axial imaging. So these are the fused PET-CT and CT images. Here we can see the physiological tracer uptake in the enlarged gland, and in the follow-up imaging, a hypodensity was noted, likely representing pituitary apoplexy. So in the gallium Dotanoff PET-CT, the parathyroid adenomas were visible with mild tracer avidity. And after the total thyroidectomy, there was no areas of abnormal focus in the neck. These images are showing multiple lytic lesions in the left head of humerus, right iliac bone, acetabulum and istiopubic ramus, showing mild tracer avidity and cortical breaks representing brown tumors. A non-tracer avid, up to centimetric sized nodule was noted in the basal segment of the left lung, which does not show any significant interval change in the follow-up imaging. This image is showing large tracer avid, which is more than liver, soft tissue lesion in the right adrenal gland, and the similar nodularity is also noted in the left adrenal gland, which does not show any significant tracer change, interval change in the follow-up imaging. Another area of focal tracer avidity is noted in the tail of pancreas, which does not reveal any change in the NCCT. Similar pancreatic lesion was also noted in the body of pancreas. Multiple nodular lesions were also noted with variable tracer avidity in the left adrenal gland, which does not show any significant interval change in the follow-up imaging. So because the tracer avidity of the adrenal lesion was more than liver, a imaging suspicious of pheochromocytoma was raised. However, the clinical suspicious was low, so iodine 131 MIBG was done to rule out pheochromocytoma. However, it does not reveal any area of significant tracer avidity, making the diagnosis of pheochromocytoma less likely. However, a new interesting finding was noted in the post-surgery images. Area of tracer avidity is noted in the second part of duodenum, which was not seen previously. Thank you.
Thank you, Dr. Arun and Dr. Yogita, for your lucid presentation of the radiological and functional imaging findings. So I'd like to summarize both the radiological and functional imaging. In the pituitary, we have a macroadenoma with partial apoplexy and a residual microadenoma component. All the 4 parathyroid glands were identified to be enlarged on the 4DCT and system-AB scans. In the pancreas, we have 3 DOTA-avid enhancing lesions, likely neuroendocrine tumors. In the adrenals, 4 DOTA-avid MIBG non-avid lesions in both the adrenals, largest one in the right adrenal, and a DOTA non-avid nodule in the left lung lower lobe with no significant change in the size over the past 3 months. So going forward, what is the likely cause of the endogenous Cushing syndrome? So because the ACTH levels are more than 10 picograms per ml with more than 50% suppression on the high dose DEXA suppression test, and there being imaging findings suggestive of a pituitary adenoma, the likely source is the ACTH dependent Cushing syndrome. Thus, the diagnosis so far in the patient is primary hyperparathyroidism, all 4 adenomas localized, with pancreatic neuroendocrine tumors multiple, pituitary microadenoma with partial apoplexy with acromegaly and hyperprolactinemia, endogenous Cushing syndrome, likely ACTH dependent, bilateral adrenal lesions which are DOTA-avid, MIBG non-avid, and a left lung lower lobe nodule, likely neoplastic. So the possibility of MEN1 syndrome with above involved organs was considered, and a whole exome sequencing was sent to MedGenome lab, which showed a pathogenic heterozygous duplication in the exon 2 of the MEN1 gene, along with a heterozygous missense variant in the exon 5 of the aryl hydrocarbon receptor interacting protein gene, which was considered to be a variant of uncertain significance. Going forwards, she underwent a bilateral neck exploration and total parathyroidectomy on 11th of September 2023 under Professor Sinu and the Surgery Unit 4 team, and a distal pancreatosplenectomy on 31st of October 2023 under Professor Sujay Paul and the GI Surgery team. Also, for the treatment of acromegaly and hyperprolactinemia, she was started on cabergoline tablets 0.25 milligrams twice a week since 16th of September 2023. To characterize the adrenal lesions, she also underwent a CT-guided adrenal biopsy from the largest right adrenal lesion on 19th of October 2023. Now, I would like to invite Dr. Nayan Krishna from Department of Pathology to talk about the histopathological findings in the patient.
Good afternoon. I'll be discussing the histopathology. We have received 3 specimens of this patient. We received a distal pancreatic splenectomy and adrenal biopsy and 4 parathyroids. So the first specimen we received were parathyroid glands. They were labeled as right superior, right inferior, left superior, and left inferior parathyroid, weighing 0.58 grams, 6.18 grams, 3.19, and 1 gram respectively. On microscopic examination, we could see a well-circumscribed, thinly capsulated tumor composed of predominantly chief cells and features suggestive of a parathyroid adenoma in all the 4 parathyroids. This was followed by distal pancreatic splenectomy. On the serial sectioning of the pancreas and on microscopy, we found 3 large tumors, the largest of them measuring 29 by 20 mm and followed by another tumor measuring 15 by 12 by 10 mm. These tumors showed features of a neuroendocrine tumor. Also, we saw many small tumors measuring between 0.5 to 5 millimeter in size that will fall under the category of microadenomas. They showed similar cellular characteristics of such as neuroendocrine tumors. On immunohistochemistry, chromogranin was positive, ACTH was negative, and Ki67 labeling index was 1%. So this was reported as the multiple neuroendocrine tumors along with microadenomatosis, WHO grade 1. We also received a right adrenal gland biopsy. On microscopic examination, we could see tumor cells, a lesion composed of cells arranged in nest, trabeculae, and quads. These cells had multivacuolated cytoplasm. And on the immunohistochemistry, it was positive for calretinine that favored a cortical origin. We also did chromogranin, which was negative, so that ruled out pheochromocytoma. ACTH was again negative. Ki67 labeling was less than 1%. So all this was in favor of a adrenocortical nodular disease. So we reported a parathyroid as parathyroid adenomas of right superior, right inferior, left superior, and left inferior glands. Multifocal neuroendocrine tumors of WHO grade 1 with microadenomatosis in the pancreas, and an adrenocortical nodular disease on the right adrenal gland biopsy. Thank you.
Thank you, Dr. Nayantrishna, for a wonderful presentation of the histopathological findings in the patient. So going forward to the post-management follow-up, we saw that there was a significant drop of the serum calcium levels from 12.7 milligrams per deciliter to 7.4, signifying the treatment of the hyperparathyroidism. Also, the intact PTH had dropped down to up to 72 picograms per ml post-operatively. Also, the plasma chromogranin levels showed a more than 50% drop post-surgery, signifying a significant response. And the serum IGF-1 and serum prolactin levels were within normal range for the patient's age and sex on cabergoline therapy. But the post-overnight DEXA suppression test and the 11 p.m. salivary cortisol were still significantly elevated above the reference ranges at the end of the follow-up. So coming to the final diagnosis, the diagnosis being MEN1 syndrome, which was genetically proven with primary hyperparathyroidism, pancreatic non-functioning neuroendocrine tumors, pituitary macroadenoma with partial apoplexy, with hyperprolactinemia and acromegaly, likely controlled for the time being. Also, the patient having endogenous Cushing syndrome, bilateral multiple adrenal nodules, and a left lung lower lobe nodule, likely neoplastic, which needs further evaluation. So going forwards to the discussion of the patient, MEN1 syndrome, as the name suggests, is multiple endocrine neoplasia, and thus we need to look for all the associated tumors in any patient who is suspected to have the same, of which the highest estimated prevalence is of parathyroid adenomas at 90%, followed by the enteropancreatic tumors at 30 to 70%, of which non-functioning constitutes the highest percentage. Also, the pituitary adenoma is found in 30 to 40% of the patients, prolactinoma being the most common finding. We also have a study ambispective design which was reported by Passam et al. From AIIMS New Delhi, which showed similar findings except that among the functioning enteropancreatic tumors, insulinomas were more common than gastrinomas in the cohort. Going forward, the associated tumors also include the skin lesions which are found in the patients such as collagenomas and lipomas, also adrenocortical tumors which are found in up to 40% of the patients is found in this patient. So moving forward to primary hyperparathyroidism in MEN1. The peculiarities being that it has up to 100% penetrance by the age of 50 years with multiple glands being involved with a higher risk of recurrence following a focused parathyroidectomy, and they are seen at an earlier age of onset compared to sporadic tumors such as 20 to 25 years, the youngest being reported at 4 years of age. Thus, it is very important to completely excise all the parathyroid lesions at one go. Also, another study, ambidextrous design, which reported 23 MEN1 patients with PHPT, showed that MEN1 with PHPT patients had a younger age at onset with lower mean serum calcium and ALP levels and a lower bone mineral density at lumbar spine and femoral neck. Also, they were found to have a higher rate of nephrolithiasis in the same patients. Coming to the pancreatic neuroendocrine tumors in MEN1 syndrome, it has been shown multiple times that the currently available biomarkers have very low efficacy in diagnosing the same, and thus clinical suspicion and imaging is of paramount importance. They are often multifocal and multifunctional, thus the surgery is decided upon by both the functionality and the size of the lesions. It has also been shown that these tumors have a higher residual risk of recurrence in MEN1 patients, and these are the most common cause of mortality in MEN1 patients along with the thymic carcinoids. Coming to the pituitary adenomas, in a study of 324 MEN1 patients, it was shown that it was present in 42% of the patients and was associated with multiplicity of lesions in a single patient, younger age at onset, higher rate of macroadenomas, and invasiveness into the cavernous sinus with a worse treatment response compared to the sporadic population. Coming to the Cushing syndrome and MEN1, of 400 MEN1 patients screened, there were 19 who had Cushing syndrome, of which etiology was identified in 14 of them. 79% had Cushing's disease, while only 21% were diagnosed to have ACTH-independent Cushing syndrome, of which 2/3 were due to adrenocortical carcinomas. A follow-up study of the French tumor study group, including 715 MEN1 patients, showed 10% of the patients having macroadenomas, that is, lesions of size more than 1 centimeter, and of which only 11 patients were hormonally active, only 4 of them secreting cortisol, leading to ACTH-independent Cushing syndrome. Another study followed up these 9 MEN1 patients with adrenal lesions, of which 2 of them were secreting autonomously cortisol, in which the follow-up period was up to 126 months, and they showed that there was a stable disease noted during the whole follow-up. So, coming to the end, when do we suspect MEN1? So, we should always suspect MEN1 when there are 2 or more MEN1 associated endocrine tumors, first degree relative of a known MEN1 mutation carrier with a MEN1 associated tumor at presentation, patients with other suspicious features such as parathyroid adenomas before the age of 30 years, multiple parathyroid adenomas, gastrinomas, or pancreatic neuroendocrine tumors at any age, 2 or more MEN1 associated tumors that are not a part of the classical triad of pituitary, pancreas, and parathyroids. Also, we also need to note that the earliest age of manifestation has been documented as 4 years, and in a study by Makans et al., it was noted that the latest age of tumor manifestation was 83 years. Thus, it signifies that these patients need lifelong follow-up for the evaluation of any tumor occurrence. So, to conclude, we should have a very high suspicion in such patients, and thus biochemical evaluation and imaging should be tailored to the clinical suspicion, and all the associated tumors should be screened for in all patients. Genetic diagnosis and screening is of paramount importance because it leads to early detection and early intervention of the family members, and also it leads to the decrease in the mental and financial burden of follow-up that, as I showed, is lifelong for patients who don't have any genetic confirmation. And management of such patients is often complicated by the multiplicity both spatially and temporally. So at the end, I would like to thank all the departments who are involved in the treatment of the patient. Thank you. I'd like to invite Dr. Tandon to conclude his remarks. Thank you.
So I think this is a great slide to stay with, and again, it's really to put on record our sort of immense gratitude. I mean, you can see, and we might have missed maybe a couple of departments, but you can realize that this patient was with us for 3 months. We do rounds 15 days at a time, so all the faculty of the Department of Endocrinology has seen her once for 15 days. Plus, I mean, the amount of contribution from the various departments, their skills and their expertise is really this is, I think, for one patient, you get all the material for an MD radiology spot, for an MD nuclear medicine spot. All the hormones known to the world were done. So this was really extensive. It also suggests that very often you need to peel off things layer by layer. At the moment, a couple of layers have been removed. We're still effectively left with two unresolved issues, the Cushing's. Sort of has called it an ACTH dependent Cushing's, but for that we need to find a source of ACTH. We already have a two hormone producing pituitary adenoma. To have the same adenoma to secrete GH and prolactin and ACTH is a bit rare, and therefore, I mean, that's being polite, it's actually extremely rare, and it's perhaps never been reported with MEN1. It has been reported in maybe a couple of sporadic tumors. Could it be a lung carcinoid which is then secreting ACTH? But that is a non-Dotanoc avid lesion, so again, we're not very sure what's happening. So macronodular adrenal hyperplasia has also been reported in MEN1, but that is ACTH independent. So again, we have residual issues there. We have that lung nodule, and we have this new lesion which has been brought about in nuclear medicine, which is perhaps in the second part of D2. So it's an incredibly complex patient. This is 3 months of work in 30 minutes. And as I said, once again, an immense contribution from a lot of people and their teams who are sitting in the room. Like to thank them once again before opening it up for discussion and comments by anybody. I think Shipra's possibly used up a year's supply of monoclonal antibodies in sorting out this particular patient. So, do you have any comments, Shipra, at this point?
In particular, but yeah, we had to actually take multiple post-sections from the pancreas to look for those microadenoma which were not visibly on gross examination.
Dr. Bal?
Getting bit worried about these adrenal lesions. Adrenal nodular lesion, is it clinical term?
So it's, well, we asked the pathologist if it's a pathological term, but Dr. Deva, any additional comments from a radiological perspective? Anything?
I mean, it is even from our side to design a protocol to cover all these things in one go is also complicated, because normally we do a arterial phase, venous phase for parathyroid, arterial venous phase for, they are located in different locations. So that was one challenge, but otherwise it is a challenging case for us also to relate everything together. Where the nodule, I mean, what is the cause of that nodule? Is it metastatic or a cause which is secreting ACTH? So those were all complex. And I think radiology literature says that there's a terminology called adenocortical tumors. And we are not able to differentiate benign from malignant tumors, especially in children. They are called as adenocortical tumors. This adenocortical nodular lesion is a part of that spectrum, or is it?
So we called it nodular disease because it was multifocal and bilateral. So it is compatible with that. If you just ask us to opine on the two-cut biopsy, then it is an endocortical lesion.
Okay.
Because it's a two-cut. There was no mitosis on this biopsy, but I made an excision to comment on the invasive features that increase mitochondria.
Dr. Sinu, as the operating surgeon for the parathyroid, your comments. So the only thing from our side that I'd just like to reiterate is that when we have a high index of suspicion for MEN1, we'd obviously like the surgeons to move from a focused parathyroidectomy to a more comprehensive evaluation. And our second problem, as Saurav mentioned, is that a lot of these lesions can come up in future again. So it's not that, though they've been removed, so again, a follow-up is critical for us. But maybe your comments on this particular
The
patient.
problem is made easier by all of you. You, the radiology, nuclear medicine. See, the only thing we find is that basically, as you said, instead of a focused, we have to do a total parathyroidectomy. And that may not be actually enough. We have to keep them on the subsequent follow-up to see whether they develop any other patients.
Actually, to remember, we have many times discussed why AIIMS is negative, and ultimately historically proved that AIIMS is more specific than endocrinology.
On that great note, I think it's 3 o'clock. The surgeons are invited. Thank you so much.
कॉपी कर देना टेस्ट कॉपी भी टेस्ट कॉपी Very good afternoon, all. So I like to extend my welcome from Surgery Unit 4, Department of Surgery. We have a very interesting case, and we have titled it. I think stolen the title from a very famous movie, The Crouching Tiger and Hidden Dragon, and we have modeled it to Crouching Tiger and Hidden Danger. So this case actually reiterates that some innocuous symptoms can hide something big behind them. The clinical case presentation will be done by Dr. Sachin, junior resident from our unit. The discussion part will be done by Dr. Abhinav Kumar, who is the MCH senior resident from our department, and will be held by Department of Radiodiagnosis and Pathology. I'll now like to hand over the mic to Dr. Sachin.
Thank you, sir. I'm Dr. Sachin, Department of Surgery. I'll be discussing an interesting case from Surgery Unit 4, which is titled as Crouching Tiger and Hidden Danger. Our patient is a 28-year-old female housemaker, and she is residing in Meerut, UP. She presented to us with the chief complaints of pain abdomen since 3 months, which was in right flank, insidious in onset, dull aching, continuous, gradually progressing. However, there was no radiation or referred pain, or there was no history of migration or shifting pain. There were no diurnal or postural variation, and there was no seasonal variation, and there were no aggravating or relieving factors. Coming on to history, there was nothing significant history. There were no GI symptoms, there were no genitourinary symptoms, there were no hepatobiliary symptoms, and there was no history of weight loss or loss of appetite. There was no history of chronic cough or urinary temperature. There were no contributory past history or family history or obstetric history. She is a para 2 living 2 with the last menstrual period was 1 week ago when she was presented to us. On general physical examination, she was conscious, oriented and cooperative for examination, and she was moderately built and nourished. Vitals were within stable. There was no pallor, icterus, cyanosis or clubbing, and there was no generalized lymphadenopathy. On further systemic examination, which revealed no abnormality. On abdominal examination, on inspection, there was a fullness noted in the right lumbar region, and there were no other significant inspectory findings. On palpation, there was a 4 x 4 cm intra-abdominal lump was noted in the right lumbar region. There was no local rise of temperature. It was non-tender. The surface was smooth. The consistency was firm, and the margins were ill-defined. And it was bimanually palpable at renal angle, and it was not palatable, with minimal horizontal mobility, and we could insinuate our finger between the costal margin and the upper border of the mass. And it was moving with respiration, limited mobility, and the mass was dull on percussion at renal angle. With the following history and the clinical examination, the differential diagnosis of us would be renal mass owing to its pain at the lumbar region, and on clinical examination there was a flank mass with restricted mobility, and the other differentials would be retroperitoneal tumor, non-functional adrenal tumor, and the colonic mass. On further workup, the laboratory parameters, hemogram was within normal limits, kidney function and liver function was within normal limits, and our urea and creatinine was 26 and creatinine was 0.5. She underwent ultrasound outside, which showed 8 x 7 cm lesion arising near the right renal ileum and compressing the IVC, which was biopsied outside. Now I would like to invite Dr. Arun, Department of radiology to discuss about radiological findings.
Good afternoon, sir. I have been provided with contrast enhanced MRI abdomen images of a patient, which was done on April of 2003. These are the 2023. These are the representative images. Here we see there is a large, well-defined solid lobulated mass lesion seen in the retroperitoneum on the right side. The size of lesion is approx 9 cross 4.3 centimeter. Lesion is seen infiltrating the infrarenal IVC, which is extending from 5 o'clock position up to the 11 o'clock position. Involving the lesion is having a both intraluminal and the large extraluminal component, which is better appreciated on the axial images. The lesion is appear mildly hyperintense on T2 weighted images, isointense on T1 weighted images, and lesion is showing significant diffusion restriction is seen on the diffusion weighted images. On post contrast images, lesion showing heterogeneous enhancement on post contrast images. Now coming back to the relations with the surrounding structure. In the first image, this is the pancreas. Here we see the lesion is closely abutting the uncinate process of pancreas with loss of fat planes. On the second image, this is the third part of duodenum. On the superior aspects, it is abutting the inferior aspect of third part of duodenum and fat planes are appear to be lost. These are the corneal MIP images. Here we see the renal on the superior aspect. Renal lesion is abutting the renal hilum. Here we see the right renal artery and the right renal arteries and the vein, which is seen draping on the superior aspect around the lesion. However, no evidence of any filling defects seen within the lesion. So there is no any fat component seen within the lesion. So the possibility of liposarcoma should be ruled out. No obvious extension into the neurogenic foramina. So possibility of neurogenic tumor is ruled out. Neural foramina. And the lesion is appear mildly hyperintense on T2. So this is not T2 bright. So possibility of paraganglioma should also be ruled out. No. So lesion is seen predominantly on the right side. However, here we see the left renal vein and the left renal artery appear free from the lesion. So on summarizing the findings, there is a large lobulated solid lesion involving the infrarenal IVC, both intra and the extraluminal extension, extending from 5 o'clock to 11 o'clock position. There is a loss of fat planes with third part of duodenum and ulcerate process of pancreas with abutment and the draping of right renal vessels. So we keep the possibility of primary malignant retroperitoneal tumor, which is either involving or arising from IVC. So we keep two possible differential diagnoses in our case. First is IVC leiomyosarcoma, second is retroperitoneal leiomyosarcoma or undifferentiated pleomorphic sarcoma.
Thank you, Dr. Arun. That was very well presented. Based on the clinical findings and radiological findings, working diagnosis of query inferior vena cava tumor, query retroperitoneal tumor involving IVC was made, and plan was made for surgical exploratory laparotomy and proceed. Now I would like to invite Dr. Krishna sir to discuss upon surgical challenges.
Now this case presented certain unique challenges to us. The first was, as we saw radiologically, it was a pretty large tumor, which was, we didn't know whether it was arising primarily from the IVC or a retroperitoneal tumor with, sorry. Sir, actually the reports, she had a biopsy, but we didn't have the reports of the biopsy, sir. She didn't have the slides. It was just written some spindle cells, few spindle cells. They didn't have a proper biopsy. We didn't have the slides to review it. So there was a major segment of the IVC which was involved. So if resectable, a major chunk of the IVC need to be removed. Another thing was there was a right renal vein was almost involved, and the tumor was also very close in proximity to the left renal vein. So we would have taken out the right kidney, but the problem is we cannot take out both the kidneys. So we had to plan for either an auto transplantation of the left kidney or maybe a reimplantation of the left renal vein into the graft. The other thing was there was a possible involvement of the duodenum in the uncinate process on radiologically. So in order to achieve a R0 resection, maybe we might have to do even a pancreatoduodenectomy for this patient. And obviously, because it's a major surgical endeavor, the possibility of massive bed loss was always there. Now it is at this time that we approached Professor Devguru from CT Wales, and he was kind enough to help us out, and he provided his OT. Cardiac anesthesia evaluation was done. Cardiopulmonary bypass was kept on standby, and owing to the anticipated blood loss, we also had a cell saver in place, and we arranged for a Dacron or PTFE IVC prosthetic graft to replace the IVC. Now, this patient finally underwent an exploratory laparotomy. There was an en bloc excision of the retroperitoneal mass with a right radical nephrectomy, resection of the entire infrarenal IVC, and the IVC was reconstructed using a prosthetic graft. Patient was under general anesthesia with arterial central venous line and a femoral catheter for a partial bypass. We did a midline vertical incision from xiphoid to pubic symphysis, did a exploration to rule out any metastatic disease, and a complete right medial distal rotation was done, that is the cattle brush maneuver, to expose the IVC. So this was the entire IVC which was exposed from the liver. So this is the head end. So this is the liver, and we are going till the iliac bifurcation. So you can see the entire IVC here. So this was a large lobulated tumor which was occupying the renal hilum and was inseparable from the right margin of the IVC. This is the left renal vein which is slung by the red color sling, and then this is the infrahepatic IVC, and this is the infrarenal IVC, and this is the IVC just above the common iliac vein. So we were able to dissect the entire IVC along the entire length. Now the next challenge was, maybe I can show you this, next challenge was, where do we place the clamp? Should we place the clamp below the liver, or should we place the clamp infrarenal? The problem with placing the clamp of horizontal infrarenal clamp was that we were not getting an adequate margin. So we place an oblique clamp here. We place an oblique clamp so that we maintain the continuity of the left renal vein with the IVC, and we did not have to clamp the left renal vein, preserving the function of the left renal vein. So we were able to remove the entire IVC along with the kidney after ligating the renal artery and the ureter. The patient, before clamping, the patient was heparinized with around 250 milligrams of heparin, and the IVC was clamped, and then the entire length of IVC was replaced by an 18 mm gel weave graft. About 9 to 10 centimeter was placed. The clamps were removed, hemostasis was secured, and we placed an 18 French drain. So this was the excised lesion. You can see this is the kidney. There's a tumor which was involving the entire hilum, and you can see the feeding tube inside the lumen of the IVC. So this tumor had both the intraluminal component and a large exophytic component also. I'd like to invite Dr. Sachin to kindly proceed with the postoperative notes.
Thank you, sir. Now coming to postoperative course. On post-op day 0, she was electively ventilated overnight. She was in CTVS ICU with minimal NORAD support, and 3-pin PRBC was given. She was on injection heparin. On post-op day 1, she was extubated and her urine output was adequate, and the requirement for inotropic support was decreased to 0.2 ml per hour. And she was on injection heparin, and her abdominal drain output was 200 ml, serous. There was serous conversion. On post-op day 2, there was sudden increase in abdominal drain output around 700 ml, which was continuous and sanguinous, it means bloody. And clinically, she was drowsy. There was hypotension, tachycardia, and there was associated decrease in urine output. Following which, we immediately withheld the heparin and warfarin infusion. Blood and blood products were given. On post-op day 3, she was improved and she was doing fine. On post-op day 4, her urine output was adequate and she was allowed orally. On post-op day 5, she was pain-free and comfortable and vitals were stable. On post-op day 9, she underwent ultrasound which showed no IVC thrombus or perigraph subhepatic collection. And on post-op day 10, her drain was removed and she was discharged. Now I would like to call Dr. Dipali, SR Pathology, to discuss about pathological findings.
Good afternoon, everyone. We received an en bloc specimen of retroperitoneal mass with infrarenal inferior vena cava segment and right nephrectomy. As we can see here, grossly the kidney was unremarkable, and we had a large fleshy lobulated tumor arising from the inferior vena cava, which was approximately 10.6 into 4.5 into 6 centimeters in size. So on microscopy, we saw a spindle cell malignant mesenchymal tumor, which had a pseudocapsule. It was arising from the wall of the IVC, and the spindle cells were arranged in intersecting fascicles and bundles, and it was hypercellular with a lot of vasculature. So the cells showed marked cellular pleomorphism and tumor giant cell formation with areas of coagulative tumor necrosis, There was brisk mitosis with about 26 per 10 high power field mitotic figures. So based on morphology, we consider the differential diagnosis of a gastrointestinal stromal tumor, leiomyosarcoma, liposarcoma, and malignant peripheral nerve sheath tumor. Immunohistochemistry was performed and CD117, DOC1, MDM2, and S100 protein were negative. SMA, smooth muscle actin, and SMMHC were, however, positive. So, based on the immunohistochemistry, we ruled out GIST, liposarcoma, MPNST, and leiomyosarcoma was considered as a diagnosis. So, based on the morphological features and on the immunohistochemistry, a diagnosis of leiomyosarcoma grade 3 based on the FNC LCC grading system was given.
Thank you, ma'am. Based on clinical findings, radiological findings, and intraoperative findings, and finally the histopathological findings, we made a final diagnosis of IVC leiomyosarcoma grade 3. And she was under follow-up, regular follow-up. Her last follow-up was 1 month ago. She's doing fine, and there was no DVT in limb edema, and she's on oral anticoagulant, and her serum creatinine is 1.1 mg per deciliter. Now I would like to invite Dr. Apina, Sir, Department of Surgery, for further discussion and review of literature. Thank you.
Thank you, Dr. Sajin, for the wonderful presentation. And I am going to talk about the review of literature of IVC tumor. So that IVC leiomyosarcoma is extremely rare with the poor prognosis. Till now, less than 700 cases have been described in literature. And these cases are in the form of the case series and the case report. And it was first described by Pearl in 1871 when he was performing autopsy. And it was first surgically dissected by Melchior in 1928. Its prognosis depends on the early diagnosis and the proper management as like other tumor. And its median survival is 2 years to 5 years. Now coming to the quick review of the anatomy of the IVC, that IVC is divided into 3 parts, that the upper segment, middle segment, and the lower segment. And the lower segment, it extends from the infrarenal veins to the bifurcation. And middle segment, it is from the renal and the hepatic vein. This one is the middle segment. And the upper segment, that is the suprahepatic, that is between the hepatic vein to the right atrium. So this leiomyosarcoma is arise from the smooth muscle cells of the vena cava. This vena cava mainly from the tunica media. This venous leiomyosarcoma are 5 times more common than the arterial ones, and among all the leiomyosarcoma, 50% of them originate from the IVC. Coming to the classification of IVC tumor, this IVC tumor is classified either on primary or secondary. Primary tumor is directly arise from the inferior vena cava, and the secondary tumor is arise from the adjacent organ, and it invades the IVC. Like if it is arise from the that adrenal gland, pheochromocytoma can be there, RCC can be there, and it invades the IVC. Another classification is anatomical classification, in that the suprahepatic, retrohepatic, and the lower IVC tumor is there. In that the retrohepatic part is the most common, and this is our case also. In the pathological classification, that is primarily it is exophytic and primarily intraluminal, and combined variety is also there, in that the exophytic and the intraluminal both component are there. And in that as we see in the microscopic view, that our case is also there. And these patients usually present at the 5th and 6th decade, and the female more common in the female, almost 5 times. Unfortunately, these rare tumor has non-specific signs and symptoms are non-specific, and the most common symptoms are abdominal pain, and its symptoms are depend on the location of the IVC tumor. If it is present in the IVC upper IVC, then it can present may be present as a Budd-Chiari syndrome, and hepatomegaly, jaundice, and ascites could be there. And if middle IVC involvement is there, then the nephrotic syndrome and the right hypochondrium vein pain is there. And if lower IVC involvement is there, then the lower extremity or lower limb edema is there.
And as we further diagnosis, that ultrasound is done. It is the initial screening test, and it assesses the vascularity of the tumor. It also differentiates the IVC tumor from the intraluminal thrombus. And for better anatomical delineation, CCT is done, and CCT is done also to do the biopsy, CT guided biopsy for the exophatic growth. And but in CCT it is difficult to differentiate between the primary or secondary IVC tumor. For that, the MRI is done. MRI is the investigation of choice for the that IVC tumor, and in that MR venography is also done to assess the patency. And for the management purpose, we have to assess the collateral venous system in the patient, and for that we look for the limb edema clinically, and intraoperatively venogram and the CECT coupled with 3D reconstruction is used for see the collateral venous system. That management is mostly surgical, and it is multidisciplinary approach is needed in that, and in that the excision with the 1 centimeter negative margin is needed. So surgical approach for IVC tumor according to the type of IVC tumor, according to the location. The type 1 tumor is excision and the simple ligation if adequate collaterals is there, if excision and reconstruction if no collaterals is there. And for type 2 there are different modalities of treatment, and excision of involved IVC is there, then that is removed, and the reconstruction with the graft. If nephrectomy is needed, then we can go for the nephrectomy. If renal autotransplantation is also can be done. But in type 1, we can simple ligation avoid the complication associated with the vascular reconstruction, thrombosis, hemorrhage, infection, and the anticoagulation therapy. So that in type 1, we prefer to go for the ligation. In type 3, it is a complex procedure, and in that we do excision of the tumor. If the liver is involved, then we also do the partial hepatectomy. And after the hepatectomy, IVC and hepatic vein reconstruction done by the prosthetic grafts. And if the right atrium is involved, then we do the cavo arterial reconstruction with the pericardial patch. These are the studies. These are the studies done, and these all form in the case series. And most of the cases done by the Wachel et al. In 2015, and experience of 40 years. And he did means all type of surgery for the IVC management. But most of the cases is done by graft prosthesis, and in all the patient has good survival, means 5-year survival is 55%. In other studies also it gives the good survival rate is 77 to 87%. In some patient that also complication with the graft thrombosis is also seen, so that the perioperative anticoagulation should be considered in these patients. Role of chemotherapy, that neoadjuvant chemotherapy is required in borderline unresectable tumor, and a combination of dacarbazine, doxorubicin, cyclophosphamide, and the ifosfamide is tried, but there is no standard chemo agent is given till now. Radiotherapy, the adjuvant radiotherapy considered in patient with a microscopically positive margin, and it decreases the risk of the local recurrence. That molecular targeted therapy is also tried, and it is under currently under investigation. That use of insulin like growth factor 1 receptor antibody blockade, mTOR blockade, and PARP inhibitor is used in the management of the soft tissue sarcoma or leiomyosarcoma. These leiomyosarcoma of the IVC, main predictor of survival is the curative radical resection with the negative margin, and tumor size and absence of the metastatic disease. And poor prognosis factor are the upper IVC involvement, that is the suprahepatic part, and lower limb edema, Budd-Chiari syndrome, IVC occlusion, distant metastasis. After the surgery, and if we achieve the negative margin, 3-year and 5-year survival rate is 76% and 68%. And as in our case, that middle segment tumor has a better prognosis. To conclude, that primary IVC leiomyosarcoma is rare tumor which is invariably malignant, and it is slow growing tumor with delayed incautious non-specific presentation, give a high yield of suspicion of this tumor. and that MRI is the investigation of choice, and the surgery is now challenging, but its treatment, it's the treatment of choice. The role of chemotherapy in radiotherapy is not clear. Now I looked at questions.
Thank you, Dr. Abhinav. So I'd like to acknowledge the CTBS team, especially Professor Devguru, for being kind enough to give us this OT. The cardiac anesthesia team led by Dr. Poonam, radiology, Dr. Atin and Dr. Ankur, they have been helping us for many years now, and from pathology, Dr. Asudhan. And it has been a team effort. We were able to do this, and we were able to achieve a good outcome in this patient. So I will be happy to take any questions. Thank you.
See, both these cases actually underline the importance of multidisciplinary approach. So that is the important thing. And the second important thing is to be pre-armed when you go into the operation theatre. And herein comes I acknowledge our immense thanks to our radiology colleagues. We literally discuss all these cases threadbare in our radiology conference, so that we do not have any surprises in the operation theatre. And we discussed as to like what Krishna was telling, that where is the left renal vein, where is it joining, what is the amount of the length of the IVC which is available proximal to it. So all these are discussed so that when we go into the operation theatre, we do not face any surprises. And for the surgeon, the most important thing to understand is that we should attempt all these daunting ventures only if you can achieve an R0 resection. So that is also again extremely important that you discuss in your radiology conference that it is possible to excise this tumor. There are no metastases. That's why it is extremely important to do an exploratory laparotomy. If you find a small lesion in the liver or something, do a biopsy, do a frozen section, because if you do not do an R0 resection, these tumors come back with vengeance. So such a formidable venture, if you take up, you should take it up only when you can do an R0 resection. Any questions? Sunil, any comments?
No, I think very well. Congratulations.
Bal? Like we did think of the possible doing a biopsy, but our radiologists are almost certain that it is ivc sarcoma. So that's why we did not go ahead to do it. And we were not having any other possibility in mind which can be tackled by either neoadjuvant chemotherapy or radiotherapy.
One kidney is gone, and only one kidney left. Radiotherapy will damage the healthy kidney.
But we were able to get a R0 margin. There was
R0, so there is no indication for radiotherapy as such. Again, neoadjuvant radiotherapy has not great role, but neoadjuvant with the availability of the target available. Yeah, adjuvant.
This patient does not.
By the recommendations, the patient doesn't warrant radiotherapy. If there are no questions, thank you all.